This conference will now be recorded.
Acute kidney injury on ECMO. So the kidney failure is that's the most frequent organ that fails in any sick patient, leave alone ECMO, because that's the sacrificial lamb. And be it hypoxia or hypoperfusion, it's the kidney that takes the hit first. So the incidence of acute kidney injury in patients on ECMO is 70% because they are the sickest of sick patients. And acute kidney injury on ECMO, which warranting renal replacement therapy, the incidence is approximately 50%. And usually they require during the first week of ECMO if they have already not been on some form of dialysis before ECMO was initiated. So what is the mechanism of acute kidney injury on ECMO? The patient-related factors. So we are the sickest of sick patients. They can have hypoxia, hypovolemia, they are on very high pressures, and the longer they have been on all this, longer the insult, more the risk of kidney injury. Nephrotoxic drugs can compound this. There is systemic inflammation and sepsis, also or dysregulation of all your hormones. More important is this, it's something that's now talked a lot about, is your organ crosstalk, your cardiorenal syndrome, and lung-kidney interactions. So what are the ECMO-related factors that cause acute kidney injury? Pigment nephropathy. So if there is hemolysis, you can have hemoglobinuria, and that in turn will cause tubular dysfunction. Shear stress, non-pulsatile retrograde renal perfusion, more so in veno-arterial ECMO. The artificial membrane also can cause profound systemic inflammatory response, and circuit-related factors. So again, hemolysis, activation of the coagulation cascade, etc. So something about cardiorenal syndrome, dysfunction of one organ begets dysfunction of the other. So when you have acute kidney injury, your heart can fail and vice versa, both because of arterial underfilling and venous congestion. So what are the indications for renal replacement therapy on ECMO? The most common is fluid overload and prevention of fluid overload. So this was an international survey across different centers in US. And as you can see from this, in respiratory indications, even in respiratory VV ECMO, it was fluid overload. That was by far the most commonest indication for renal replacement therapy. And then you have one indication is to prevent fluid overload when you anticipate that you're going to give a lot of blood products or fluids, and then only is acute kidney injury. So this is the international survey by the KIDMO group, and the modalities that were used was SCUF in these patients, CVVH, CVVHD, and CVVHDF. So coming to fluid overload, that's the most common cause for indication of instituting renal replacement therapy on patients in ECMO. And what are the causes of this fluid overload? So pre-ECMO, they could have got a lot of fluids for their shock. Circuit prime, you need fluids. There can be a surge response from oxygenator, which can cause capillary leak, causing your lungs to be wet. During ECMO, we are all guilty of this. Whenever there's chattering, our first knee-jerk response is to give fluids and then only address the underlying cause, be it your cannulae size or cannulae position, etc. So each time we give fluid boluses to our patients on ECMO, we are causing fluid overload. And volume status, as we know, has been correlated with poor outcomes, be it underfilling or overfilling. And it could be the cause or effect. So if you have a sick patient with acute kidney injury and you're not able to excrete and lose all that volume that you have given, you could worsen all your other organs. Fluid overload hinders weaning. So what are the options for fluid control? One is first restricting the amount of fluids that you give, using diuretics, and if not, you can use ultrafiltration or use your machine to do hemofiltration. So how do you calculate your fluid overload in patients? In any critically ill patient, be it with ECMO or without. So this is the fluid in minus the fluid out. by your ICU admission rate times 100. And studies, even in non-ECMO patients, have revealed convincingly that the survivors had lesser fluid overload, that is less than 10%. So fluid overload more than 10% is bad, and this is something that we have to be obsessive about. We have to calculate this in every critically ill patient, and more so patients on ECMO. So this is yet another study which showed that a positive fluid balance on day 3 of ECMO was an independent predictor of 90-day mortality, and was a strong and independent predictor even after adjusting for severity of illness and other confounding factors. So achieving euvolemia on ECMO patients confers clinical benefit. This is yet another study, 2017, which showed that survivors had a lower percentage of fluid overload, both at initiation and discontinuation. So now coming to the acute kidney injury criteria. So we all know about this rifle. In pediatrics, we have the P rifle where we use estimated creatinine clearance, not just the serum creatinine value. And as you can see, as you go down the pyramid, when you reach the failure, your survival rate also reduces. So the key is to system much earlier. We all know that serum creatinine is just a surrogate for your GFR. It is delayed. It is unreliable, and so the indication for instituting renal replacement therapy on patients on ECMO should be before your serum creatinine goes to alarming numbers. And so there are biomarkers that can be used. Something else that you have to keep in mind when your serum creatinine goes, you have to find out the cause, whether it is just shock, hypoperfusion causing that, sepsis, or is it something else like your pigment nephropathy? Is there urine hemoglobin? Look at your smears if there's profound hemolysis. Look at your bladder pressures, do an ultrasound. Is that contributing to your rise in serum creatinine? Now, this is another index that is very, very valuable, and that you can keep. It's actually like your troponins, your myocardial infarction. So before your kidney fails, this is something that you can calculate, and the higher the scores of 40 is maximum. So the first are all the risk levels. So is your patient septic, ICU admitted, ventilation inotropy? So ECMO patients are very sick and they are at high risk. And of course your injury. So look at this, under injury, you can see fluid overload is also scored, and that increases your renal angina index, which predicts that this patient would require renal replacement therapy. Yet another criteria for instituting renal replacement therapy on ECMO patients is your acidosis. And the acidosis need not be only due to shock or sepsis, it could be liver dysfunction profound, where you're not able to maintain your pH because of high lactate, or poisonings, for which the ECMO was instituted. Now, CRRT on renal replacement therapy on ECMO, this is a study that has shown that even your cytokines can be removed in these sick patients. So it actually helps to institute this modality early. So use of CVVH in ECMO was associated with, this is a study in pediatric respiratory failure, which showed that early CVVH improved fluid balance. They could get more calorie to the patient, and less diuretics were used. So what about recovery? Renal recovery is good in those who survived ECMO. And this is a study in pediatrics, 2015 and 2011. So what are the factors that affect survival on ECMO for patients whom dialysis was instituted? One is the time. So you institute it early, you have a better survival. And also, of course, renal function at ECMO initiation and fluid balance. So earlier the better, as I already mentioned. And so you see, it is so, so you have your survivors where the median time to initiation of CRRT was 1.6 days, as opposed to non-survivors who the CRRT was initiated 1.9 days later. So it is so time sensitive instituting this modality. So this is the same study which showed that patients with CVVH ECMO, the days to desired calories, this was better. Survival was also better on patients who had both ECMO and CVVH. So to sum up, why do we need renal replacement therapy on ECMO? You can manage your fluid balance precisely. It prevents fluid overload. And once you have fluid overload, it helps reduce the fluid overload. It removes your inflammatory mediators, both caused by sepsis or by the ECMO per se. You can have better control of your electrolytes, your acidosis, your potassium. There is reduced need for decreased use of furosemide, and you can have better nutrition support. So how do we give renal replacement therapy on ECMO? It can be with an inline hemofilter, just a simple filter that is introduced into the ECMO circuit, or it can be with a cumbersome CRRT machine. So talking about the filter, so you have your stuff. So just remember that your ultrafiltrate, this can only remove fluids. So a filter that is instituted into the ECMO machine can only remove fluids, not the solutes. Of course, peritoneal dialysis, we would not do it on patients on ECMO because they are anticoagulated. So what is the advantage of just an inline filter? It is simple, it is easy to set up. You just have a small shunt. It pulls large volume of fluids quickly, much more than diuretics, without the electrolyte imbalance. It can control. You can control the fluid removal even with these filters with an infusion pumps. And it's good for volume overload and removal of certain drugs. What is the disadvantage? The filter longevity. Because of the high blood flow, the filter generally packs up within 6-8 hours. You cannot accurately measure the ultrafiltrate, so you cannot calculate the fluid balance accurately, and there is poor solute clearance. So having a filter in the ECMO mesh circuit is only to remove fluids. Now, when would you institute this? When you have the CRRT machine, when you need to remove solutes, when you need to remove cytokines, and when you need to correct aggressively the electrolyte abnormalities. So this is the ECMO, the patient with the ECMO machine and the CRRT, all in line. So the advantage of this, the CRRT, you can control your fluid removal, but they're more expensive disposables. It takes a longer time to set up, but it's a lot more safer. Now, this is the difference. So hemofilter is IV pump control. CRRT, the ultrafiltrate is controlled by the machine. There's no metabolic control with the hemofilter. With CRRT, you can. ECMO flow, there is some shunt, whereas there's no shunt because there's some blood that goes through the filter. Whereas CRRT, no systemic changes. And anticoagulation, you need both heparin. So you have, when you say CRRT machine that is hooked up into the ECMO, you can give CVVH. CVVHD, which is hemodialysis. So CVVH is just convection. Here you have dialysis, and CVVHD, which uses both convection and dialysis, that is diffusion. So diffusion is for smaller molecules. So when you use the word dialysis, it is diffusion. The mechanism of solute removal is diffusion. When I say ultrafiltration and CVVH, it is convection. So middle and large molecules are removed by convection. Whereas when you just mention the word ultrafiltration, it's only fluid removal. So larger molecular weight solutes are removed better by convective clearance. So middle molecules. So in sepsis, we are more worried about our middle molecules. So theoretically, it makes sense to institute CVVH or CVVH-DF, where you do have your convective clearance. So why in CRRT, why not intermittent hemodialysis or SLED in these sick patients? Because you have better solute clearance, and more important is your steady, gentle fluid control removal per unit of time. So intermittent hemodialysis, there are large fluid shifts, which is not ideal in patients in shock. And also there are osmolar shifts, so you can have hyponatremia, more cerebral edema, which is something you want to avoid in patients with liver failures, with CNS involvement or cardiac failure. SLED, there is frequent disconnection, so there's more risk of infection. So if you can afford it, if you can manage, if you have the expertise, then having the CRRT continuously in line, connected to the circuit would be the best option. So how to connect a CRRT to ECMO? It can be a separate dialysis catheter. It is simple. This is very simple. You can do it like you would do for any other patient, even not on ECMO. And you can connect, reconnect. There's less air into the circuit, but you need a separate site, and so that is an access is a limitation. There is risk of bleeding because you're already anticoagulated the patient on ECMO. So easiest would be to connect the machine into the ECMO circuit. But the complication, disadvantages, there can be air entrainment because of so many connections, your stopcocks. There can be hemolysis, which can cause clots in the ECMO circuit. It's more complex, and there is increased heparin requirement. If you have connected your CRRT machine into the ECMO circuit, you can only prime it with saline because of the smaller CRRT size with respect to the larger ECMO circuit size, even in small children. Remember, ECMO has much higher flows while CRRT flows are very low. ECMO circuit pressures are higher. And as I said, CVV-HDF has the best solute clearance. This is something that we have observed in our pediatric patients whom we have connected CRRT to the ECMO circuit. We have noted a little more hemolysis. We do not have the luxury of measuring plasma-free hemoglobin. So this is we have noted that our carboxyhemoglobin has always gone up in our co-oximeter, blood gas, because of hemolysis. So that's something to keep in mind.
And Dr. Vamsi Krishna, madam, I work in ICU as intensivist. అంటే వీళ్ళకి ఏంటంటే మేడం పవర్ మే టేక్ సమ్ ఇంప్రూవ్మెంట్.
Sure. Hello.
Nothing. I think somebody was speaking in between. Well, please continue, ma'am.
Okay, can I continue?
Yeah.
Okay, so the risk of clotting is much higher when you have another machine and a lot of tubings into the ECMO circuit. So the blood flow should always be good, and your ultrafiltrate rate to plasma rate should be about less than 0.3. And we all know that pre-dilution fluids will improve filter life but decrease clearance of solutes. So this is something that probably you have heard about before, but I just want to re-emphasize. So the circuit, ECMO circuit before the pump has negative pressure. The ECMO circuit after the pump has got a positive pressure. So now where do you connect your CRRT inlet and outlet? And the complications, the technical considerations, all this will depend on these pressure, the negative as well as the positive. So where to connect and where not to connect. Remember, access can be anywhere. Try to avoid it pre-pump because there's more air, that because of the negative venous pressure, you are actually sucking in air, especially if you have very negative venous pressures. And so there could be some air entrainment. So, but you can get the access to the CRRT circuit from the ECMO, from anywhere, even post-oxygenator. But the return should never be post-oxygenator because it can cause air embolism. So this is just to sum up where you should be connecting and where not to connect the CRRT circuit. So now let's go through this. So access can be post-oxygenator and return pre-oxygenator. Access can be post-oxygenator and return pre-pump. So pre-pump means it is in the negative. So from a positive to a negative. But remember, there is recirculation because your oxygenated blood is going back into the deoxygenated side. So there is some amount of recirculation, but it's negligible. Okay, then access can be post-pump and return pre-pump. So that is from the positive pressure and return it to the negative pressure. So this is the most common option, and I think, most widely used option. So you take it from a positive pressure, so it's easier to suck the blood, and you return it pre-pump. So unless there are your venous pressures are very, very negative, and then there's a lot of alarming, this should not cause much problem. The other option is access post-pump and return pre-oxygenator. So both are in the positive. But remember, because your CRRT filter is exposed to such high pressures in the ECMO circuit, it can pack up a little earlier. And that's something that you have to keep in mind. You have to watch your transmembrane pressures and your filtration pressures. So access can be pre-pump, okay, and that is from the negative, and return can be post-pump. But remember, as when you're sucking from pre-pump, that's negative. So again, there can be air entrainment. Access pre-pump and return pre-pump. So both are negative. So you may have to use a clamp if there's, so that you are able to give back. So what we use in our center is access post-pump, which is the positive pressure, and return pre-pump, which is negative. So pressure differences. Now this is a screenshot of pressures only on a CRRT, patient only on CRRT, not on ECMO. And you can see the pressures, they are much lower. And this is CRRT on ECMO, in the ECMO circuit, and you can see that the pressures are much higher. Your TMP is much higher, your filtration pressures are also higher. So these are the two pressures that you have to monitor. TMP, so if your TMP, your pressures are going up, there could be clots in the filter. The clots could spread into the oxygenator. So these are things that you have to keep a close watch. So what are the technical considerations? As I said, air entrainment, if negative pressure, if you're sucking from negative pressure, if your pressures are very high, then you see there's more hemolysis. That's something that we have observed in pediatric patients. Recirculation, if you are taking the blood from post-oxygenator and giving back anywhere pre-oxygenator, shunt, but this is just minuscule, and filter failure if subjected to high pressures. So there's no uniform solution where to connect the CRRT and how to manage these pressure differences. You have to maybe change your alarms, but keep a close watch on your filter pressures because there is risk of clotting, filter failure, and clot spreading to the ECMO circuit. And this is just summarizing where you can troubleshoot and change your connections depending on your pressures. So ECMO is one modality. You can have CRRT, yet another modality on ECMO. And third modality is plasmapheresis, which has been used especially for poisoning patients for whom ECMO was instituted. And these are some studies. This is by Dr. Vivek Gupta from India. So he's done a lot of study on poisoning, ECMO for poisonings. And similarly, ECMO and therapeutic plasma exchange procedures in both pediatric and adult patients, and all of this connected to the ECMO circuit. So this hypertension, something that we have to keep a close watch when we start commencing CRRT in any sick patient is hypertension. In pediatric patients, you have some more blood going extracorporeal. The other risk is your bradykinin release syndrome, but this is was more of a problem with the previous filters, AN69, not so common now. But you have to anticipate this in acidotic patients because its filter is pH sensitive. So we generally start some pressors, we give a bit of or increase the ECMO flows, and also give some bicarb boluses. When you're on DA ECMO, it's not so much of a problem because you can increase your ECMO flows. Hypothermia, which is a problem with CRRT, can be managed well with your ECMO heater. Electrolyte disturbances also has to be corrected, especially when you're on all these dialysis. Something that you have to keep in mind is nutrient losses. So you can have amino acids which are lost when you start CRRT, and that's something that you have to remember. Once you've instituted CRRT, you can always give you a full protein requirements, and also keep in mind amino acids. Anticoagulations, heparin takes care of it, but the risk of clotting is higher, so you have to closely watch the ECMO circuit filter and monitor your ACTs. This was a patient, pediatric patient, who we proned on ECMO with the CRRT in circuit. So that's another advantage of connecting the CRRT into the ECMO circuit rather than having a separate large VAS cap on the patient. And now we have all these modalities. You can see there is a risk. You have so many connections. There's risk of disconnections. There's risk of infection. So what about drug dosing? Because there's a lot of sequestration in the ECMO circuit, a lot of blood is extracorporeal, there's volume of distribution is high in these critically ill patients. So even if once you've instituted CRRT, you have taken care of your renal failure, it is prudent to give the full, you have to give the loading dose, and it's prudent to give the full maintenance dose also, because you don't know how much of it is outside in the circuits in all their tubings, and how much is in the is with the patient. So I would advise definitely full loading and also maintenance doses. So to sum up, CRRT on ECMO, any form of renal replacement, instituted early, instituted more so for fluid overload, do not wait for acute your serum creatinine to rise or full established AKI, because then you have missed the boat and mortality is so much higher if you institute it daily. And every day delay actually increases your mortality. Remember, it is not the CRRT that kills, it is the acute kidney injury in these critically ill patients that causes mortality. Thank you. Any questions?
Yeah. Now the session is open for our discussion. So if anybody has any questions.
Sir, I have one query on regarding the attachment of this CRRT circuit.
Regarding the
attachment of CRRT circuit to ECMO circuit. Ma'am, you said that if you take the access from the post pump and when we give to the post pump, then the pressures in the TMP are very high because the circuit is, because the CRRT filter is exposed to higher pressures.
Yeah.
And that means where access pressure is high as well as the return pressure is also high. If you look at this, the delta pressure is somewhat, we need to, it depends upon the pressure difference. And at the same time, if you access is from the post pump, and if you give return to the pre-pump, if you look at the pressure difference between these two very high, then the filter is exposed to the more pressure difference here compared to the pressure when we attach both the access and return in the post pump. Isn't it, ma'am? This is my question.
Yeah, I got what you mean. Correct. But this is something that I think our perfusionists are much more, I mean, they've had experience with managing the pressure differences, and they found out with this they have least complications and the filter also lasted longer. Dr. Pranay, what is your opinion?
Usually we do also the same way. We take it from the post oxygenator, the excess and the return we give to the pre-pump. So
that is from the positive pressure to the negative pressure.
And plus the air, the air going in will be minimized, and even if there's some micro air goes, that can be captured in the pump or the oxygenator. So nothing goes to the patient at least.
Yeah, I think what he was asking is the pressure difference is much higher when we connect positive to negative, right?
Yeah.
Yes, ma'am.
Okay. But then sometimes what they do is they create artificial pressures and keep it on that particular pressures only. So they have to do a lot of the technician, especially the renal technicians, has to do a lot of adjustment in the alarm limits, and then only they will able to do it. Again, the problem will be more if it's a VA ECMO as compared to VV ECMO, because in the VA ECMO the pressure changes will be much more as compared to VV ECMO. And again, it depends on the flow of the ECMO, how much the ECMO flow is. If the flow is more, again the pressure changes will be more. So it depends on multiple factors, in fact.
I think the other option, when you connect from positive to a negative, if it's too negative, people have even used clamps to
Clamps, yeah.
avoid that negative pressure, so that the pressure difference is not so much.
Okay.
Yeah. So actually, there's nothing perfect, but
Yes, ma'am.
I think they felt was the least causing the least of the problems. Hmm.
Okay. Ma'am, actually, I had one more. I had my experience regarding this connection of CRT circuit in the ECMO circuit. So it may sometimes
Yeah.
it may falsely decrease or increase the blood flow rates which we see on the ECMO console. Because what happens is, especially this, we had seen the problem in Medtronic machines where there is a transducer where that measures the blood flow uh, in between the pump and the oxygenator. So what happens is, if we access the blood from the oxygenator and given to the pre-pump, so there is some amount of the blood that is getting shunted in between. So falsely, sometimes we may see that for the same RPM, there will be decrease in the blood flow when we start CIRT. So this is the practical problem we had seen. So for that, we need to attach one more transducer to measure the what is the amount of the flow that is going to the ECMO circuit as well. So CRT circuit as well, so that it will help us to know the exact amount of the flow that is going to the ECMO circuit. Because what happens is this was a practical problem when I was in the initial stage. So when the CRT was attached to the ECMO circuit, there was decrease in the blood flow in the ECMO circuit. Then I thought that there was some problem had happened. Then that's why that is causing decreased flow in the ECMO for the same RPM. Then after discussion with our senior faculty, then they said that this is the mechanism that that is the problem. So sometimes when we use Medtronic, that may cause some problems, ma'am, and when
Oh,
circuits.
that's
So
interesting.
false.
So I wonder
Yes.
what the other machines have to monitor the blood flow.
Whenever
Yes.
you put an CRRT in the ECMO circuit, the flow is bound to go down because your resistance
Yeah.
is going to increase.
Yes,
The
sir. Yes, sir.
increase the flow is bound to go down irrespective of any machines. Okay.
Yes.
You are able to talk about Medtronic because you have a flexibility of putting uh, the transducer anywhere. But in
Yes.
Meke, you cannot change the transducers because it is going to be fixed with the pump. But
Yes.
see, rather than going and concentrating more on the flow, what we do is usually we go by a hemodynamics and the saturation. And whenever we put the patient on CRT, we assume that it might require little higher RPM. So we probably have to increase the RPM to maintain the same amount of flow to the patient and maintain the hemodynamics. So that depends on the
Oh,
clinical risk rather than going by a
yes.
stringent amount of how much flow is going to the patient.
Yes. Yes.
Yeah,
Because
I
I
think
was initially
the
confused.
flow would come down.
Yeah,
Makes
Yes.
sense.
because resistance is going to increase in the pathway.
Yes, yes.
Because I was confused when I was initially getting my training. So I thought that what happened. So I was not aware of this phenomenon. Then I could.
Any other anything else that anybody would want to share? Their experience?
Any questions? See,
I
Dr.
think the
Vivek,
most important message would be to avoid fluid overload and institute renal replacement for that very reason, because it delays your weaning off ECMO if you have fluid overload. So acute kidney injury is just one aspect, but fluid overload is something that we should avoid in our ECMO patients. And they are all, ECMO is a setting for the patient getting waterlogged, poor lymphatics, lying always, paralysis, everything. So, and they are sick patients with capillary leak and all that systemic inflammation that goes on. So renal replacement early for that indication is very, very important.
Dr. Vivek Gupta is busy in some meeting, so we won't be able to attend today. So probably we'll keep his talk on next Thursday, that is on 1st of August. We'll keep his talk, Dr. Madan's talk, and Dr. Nanda's talk on 1st of August tentatively. I'll keep you posted on the group.
Okay, sir.
Yeah. If there are no further questions, then we'll follow up the session.
Thank you, Dr. Pranay. Thank you, everybody.
Thanks.
Thank you, ma'am.
So,
Hi, Dr. Pranay.
yeah.
How are you? I saw you finally.
Yeah.
Oh, this is
I
my
think
first webinar. Huh?
you were not able to see me because of your screen was PowerPoint mode now, so you
Yeah,
were not able.
it's very nice. Actually, quite cool, this whole thing. Huh?
Yeah, and it
Nice.
becomes easier accessible.
Yeah, it's so nice. Your clarity, I could hear you very well. And even the others participants.
Good.
Okay, sir.
Thank you.
Thank you.